Okay, lecture number 4 on extremity trauma, almost done. Let's move to an overview. We're going to discuss mechanism of injury. We're going to talk about, and then we're going to talk about some of the specific treatments for the various types of extremity traumas and fractures and so on. Okay, so mechanism of injury is really important. You may not always be able to see the mechanism of injury when you're treating somebody with an extremity injury. So taking a good history is always important. When considering treating a limb injury, you want to consider the mechanism that caused the injury, and want to think about the kinematics of trauma and how the forces transfer through the human body during the actual injury. So you can imagine that a fall where you're landing on your feet is going to injure your foot, but it's also going to transfer energy into your spine, and you may have a compression fracture of the spine. Likewise, if a patient's in the seated position and they're involved in a motor vehicle collision, then you're obviously going to expect injuries from the knee, and that energy will transfer through the femur and into the pelvis, and then dislocate the femoral head from the pelvis. Okay, so consider those mechanisms of injury when you're dealing with extremity trauma. Right. So first, we're going to talk about pelvic splinting and pelvic trauma. So it's practical to include pelvic trauma when we're talking about extremities, because the pelvis fractures and injuries are usually associated with extremity trauma based on kinematics. So pelvic injuries are usually caused by motor vehicle collisions or severe trauma such as falls from heights. They are identified by applying gentle pressure to the iliac crests of the hips and the pubis during the primary survey. So you're just going to feel the hips and the iliac crests when you're doing your primary survey. Actually, it will be during your secondary survey, and you're going to be checking for any sort of crepitation and any unstable movement of that pelvis, and that's going to tick you off to the idea that you've got a pelvic fracture, and then you want to go ahead and splint that pelvis. There's always the potential for serious hemorrhage in the pelvic fracture. So we know about those two big vessels that run in the retroperitoneal space. They also travel through the pelvis. So we could lacerate those as a result of the pelvic injuries, and there can be a lot of bleeding from that. Okay, so traditionally we've used sheets as slings to stabilize the pelvis, and there's a diagram or a visual representation of how that was done in the past. But nowadays we have purpose-built belts and straps and slings and so on for stabilizing the pelvis. Vacuum mattresses are also very useful in the pelvic fracture because they're super comfortable for the patient, or more comfortable for the patient. Remember that moving a patient with a pelvic fracture is going to exacerbate the problem, so you want to try and not move them too much. If you need to move the patient, you want to try and use a scoop stretcher to move them with, and you're going to then place them on that backboard or the vacuum mattress for the patient. Right? Manpower is needed for this, so use the available fireys that you're going to find on the scene, or anybody else that may be able to assist you. Right. Next, we're moving on to femur fractures. So the femur usually fractures at the mid-shaft, and a mid-shaft femur fracture is the fracture that we really want to apply traction to. Okay. So you may have open wounds associated with femur fractures, and if you have open wounds associated with a femur fracture, you can assume that is as a result of a compound fracture, but the bone is just kind of retracted back into the musculature surrounding the femur. There's a lot of muscle tissue surrounding the femur, and when a spasm develops after a femur fracture, bone tends to override. So if your bone is like this and you get a spasm, it's going to cause overriding, which will cause shortening. It will cause additional damage to the tissue surrounding that bone, also to the vessels and to the nerves. So it can be very painful for the patient, and that's why we want to go ahead and apply traction for that. Okay, large amount of muscle mass, large amount of bleeding can occur into the tissue of the thigh, and a bilateral femur fracture can be associated with about a 50% blood loss into those spaces around the femur. 50% of your circulating blood volume, that is, can be lost into femur fractures, so be aware of that. Next, we're going to talk about hip fractures. So hip fractures are most often in the narrow neck of the femur, where we're usually surrounded by strong ligaments, and this may occasionally allow this type of fracture to bear weight. So ligaments are very strong, and there's very little movement of bone ends in most frequent types of hip fractures. Okay. Consider hip fractures in the elderly person who has fallen and has pain in the knee, hip, or pelvic region, and the affected leg will usually be, but not always, externally rotated and shortened. So if those are your 2 feet, the fractured side will be externally rotated and shortened. So if you measure the 2 legs together, you'll find that the one leg, or the fractured leg, is shorter and externally rotated. Or should I say the fractured hip is shorter and externally rotated? The leg of the fractured hip. Provide pain relief for these patients. They're usually going to be in a lot of pain. And remember that isolated knee pain may also be as a result of damage to the hip. So just refer to that referred pain resource that I gave you in the previous weeks. Okay. Hip dislocations, you're going to treat them pretty much the same as you're going to treat hip fractures. They require quite complicated reductions in hospital. They are also severe orthopedic emergencies because of the vessels that could be entrapped in the dislocation, both in the anterior dislocation and in the posterior dislocation. You could get trapping of vessels and nerves in those dislocations, which could cause compartment syndrome. It could cause damage to the nerves, and as a result, loss of use of that limb later on down the line. So you want to try and split these. Usually bind them as you find them. Don't try to manipulate them too much. They're very, very difficult to reduce, so you want to get these patients to hospital as quickly as possible, both in the anterior and the posterior hip dislocation scenarios. Okay, knee injuries are quite serious because arteries are often bound down above and below the knee joint and are often bruised or lacerated if the joint is in an abnormal position. So treatment must be based on the circulation and neurological function below the knee and the foot. Many knee injuries later require amputation, so it's a threatened limb scenario, so it's a priority 1 case. It is important to restore circulation below the knee whenever possible, so if you can reduce it, go ahead and reduce it, but only try once. If you can't move it, or if a patient is guarded or doesn't want you to touch their leg, you want to try and bind it as you find it again and get them to hospital so that it can be properly reduced or properly sorted out by an orthopedic surgeon. Okay. If you are going to try and reduce that knee, no more than 10 pounds of pressure must be applied to the long axis of the leg. Okay. Again, pain relief, splint it, make your patients comfortable, get them to hospital, and let the orthopedic surgeons do their jobs. Okay, fractures of the tib-fib or tibia-fibula. Fractures of the lower legs are often open due to thin skin over the front of the tibia and often have significant internal or external blood loss. So remember to dress any wound and pad any bone ends that may be put under an air splint, so you don't want to puncture your air splint. Okay. Internal blood loss can interrupt circulation to the foot, and this may lead to compartment syndrome. So in the previous lecture we discussed compartment syndrome, so you understand how that develops and the process of treating it. Fractures of the tibia and fib may be splinted with a rigid splint or an air splint or a pillow. So you're only really limited by your imagination as to how you're going to split these injuries. Next we're going to talk about the clavicle. The clavicle is the most fractured bone in the body. If people fracture something, it's usually their clavicle. It's usually the first bone you fracture as a young boy playing rugby. Really, there may be injuries to the subclavian vein or artery. So the subclavian vein or artery run directly below the clavicle, and with a fracture you could cause laceration and damage to that subclavian vein and artery. But it is not a common occurrence. It's important that the ribs and the chest are carefully examined if you have a clavicle fracture. If there was a force applied to the body strong enough to fracture the clavicle, then you can assume that the ribs and the chest were also involved as a result. So again, kinematics of trauma and the transfer of forces through the body. Just keep that in mind. It has to do with your mechanism of injury. Okay. Shoulder injuries. So most shoulder injuries are not life-threatening, but they may be associated with severe injuries of the chest or neck. Many shoulder injuries are dislocations or separations of the joint spaces and may show up as a defect at the upper outer portion of the shoulder. So you'll just get a bump at the upper outer portion of the shoulder. Dislocated shoulders are very painful and quite often require a pillow between the arm and the body to hold the arm in the most comfortable position. So you want to bind this as you find it, and you want to communicate with your patient and make sure that they're as comfortable as possible. Also, don't be afraid to give these patients analgesia for these injuries. They are pretty painful. Get them to hospital so that they can reduce those dislocations or fractures, and treat symptomatically. Fractures of the elbow. Okay, it's often difficult to see the difference between a fracture or a dislocation of the elbow. You're going to treat them both in exactly the same way, so you're going to splint them. Elbow injury should always be splinted in the most comfortable position, and distal function should be clearly evaluated. So remember to check your PMS. You want to check for movement, you want to check for sensation, you want to check for pulse in these patients. Don't try and straighten the arms. If the patient keeps the arm bent, bind it in the most comfortable position for the patient and transport the patient to hospital. Fractures to the forearm and wrist are also very common, usually as a result of a fall onto an outstretched arm. So again, kinematics of trauma, and then think about where those forces were transferred to. Usually a fracture like this can be best immobilized with a rigid splint or an air splint. If a rigid splint is used, a roll of gauze in the hand will hold the arm in the most comfortable position of function. Forearm is also subject to internal bleeding, which can interrupt blood supply to the fingers and hands. And again, you want to think about compartment syndrome. You understand what compartment syndrome is and the risks associated, so you understand why it's important to get these patients to hospital as quickly as possible to get this assessed by an orthopedic surgeon and treated appropriately. All right. So injuries to the hands and the feet. So many industrial accidents involving the hand or the foot produce multiple open fractures and avulsions. So these things can look pretty gnarly. All right? If you've ever seen an avulsed foot or an avulsed hand, you'll know what I'm talking about. These injuries are often gruesome in appearance, but are seldom associated with life-threatening bleeding. And I'd just like to take this opportunity to remind everybody that when we're talking about fracturing or treating fractures and dislocations, this is going to be as part of your secondary survey. In your primary survey, the only thing you're really going to do for a fracture or a dislocation is make sure that there isn't exsanguinating bleeding, and if there's exsanguinating bleeding, you're going to put a tourniquet on it or follow your services protocol for dealing with bleeding. So that might be direct pressure followed by a tourniquet application, or just directly going for the tourniquet. I would recommend having a pretty low tolerance for bleeding. Patients that have extremity bleeding, I have a low tolerance for placing a tourniquet. So there you go. An alternative method of dressing a hand is to insert a roll of gauze in the palm and then arrange the fingers and thumb in their normal position. The entire hand is then wrapped as though it were a ball inside a very large and bulky dressing. Elevating the isolated hand or foot injury above the level of the heart will almost always dramatically reduce bleeding during transport. If it doesn't, yeah, you know what to do. Go for your tourniquet or apply direct pressure or other methods of bleeding control, depending on your services protocols for that. That brings us to the end of extremity trauma. I might see you in a little bit later in some of your other lectures.